Okay, these are top tips from Tim on Kangaroo Island. I'll make it very clear that these are based on the shoulders of giants. We'll start with airway. Rather like willies, the more you fiddle, the harder it's going to get. So you need to maximise your efforts at first pass success. Ramp the patient, ear to sternum. Use the appropriate type of bag mask valve, mindful of the fact that different manufacturers have different FiO2 for spontaneously ventilating patients. Add a PEEP valve. The most important tip is to have an airway plan and to use a checklist and to adapt it for your local environment and your local kit. When you intubate, use a bougie. Put it into the conformation shown, the so-called Kiwi grip. This means the ET tube is preloaded. You can use the angle of the jaw as a fulcrum to navigate underneath the epiglottis with the tip of the bougie and rapidly advance the ET tube. On occasions, the oropharynx is soiled with blood or vomit. A Yanker sucker may not be enough. If you take a meconium aspirator and attach via a bronchoscope adapter to an ET tube, you can suck as you go. You can then exchange for a clean tube using an Aintree catheter or a bougie. Breathing. Not really much to say here. Smart people set up their ventilators before they intubate, and my real bugbear is it should be visible at all times. We'll talk about that later. Circulation. We've gone to a lot of trouble to get IV access, maybe a rapid infuser. We need to secure it in place. There's lots of ways of making things sticky, but one of the best ways is to use superglue or Histocryl. Just a little dab will secure your art line or your IV, as well as tape and opsite. ECG dots can be really hard to secure, especially on sweaty patients. One of the best tips is to use deodorant. The aluminium hydroxide will help you fix the ECG dots to the patient. How about everything else? Well, Sun Tzu had a few things to say about position. In the resus room or at the roadside, getting 360-degree access is vital. Pete here is hemmed in by the ambos and by the crash cart. He can't see the clock nor the prompt cards on the wall behind him. He can't even see the oxylog that's on the shelf behind. If he was clever, he'd move the head end of the bed to the right of the picture. That way the only thing preventing 360-degree access would be the tethers to wall suction, oxygen and monitors. So think about 360 access. More importantly, human factors. You've got to know yourself, you've got to know your enemy, and you should practice. Simulation is one of the best ways of doing this. This is a perimortem C-section. Carry a Sharpie. Ketamine for just about everything. And finally, checklists. Checklists for absolutely everything. They will make you a safer doctor, and more importantly, they will make this man's head absolutely explode. With that, I thank you.